We welcome to the stage Halfdan Lauridsen, who seems to be a bit of a star in the Danish camp, from what I've understood. He's a senior consultant in emergency medicine in Copenhagen, a surgeon, a sailor, which we can ask about him this evening, and a systems person with a special interest also in ultrasound. But right now, we're going to listen to some systems. Welcome.
Thank you. And you said I was a surgeon. Well, I was a surgeon in my past, in my dark past. After that, I became an emergency physician. I'm a senior consultant at the emergency department in Nordsjællands Hospital. I treat patients and I treat numbers. And I would encourage you all to look at your numbers because you'll find things which are interesting. But let's start with the conclusions. If you create an independent emergency department, you can facilitate a reduction in patients admitted to the rest of the hospital. You can decrease the amount of hospital beds by 21%, even in light of 20% more patient contacts. You can reduce emergency department crowding by 85% at levels above 130%. You can reduce in-hospital crowding. You can reduce emergency department cardiac arrests without increasing in-hospital cardiac arrests. The best treatment of a cardiac arrest is preventing it from ever happening. No matter how many compressions or whatever you treat, prevent it from happening. And you do that by reducing crowding. And you can reduce the in-hospital tasks that other people need to do. So emergency medicine is a driver of hospital efficiency, and I can leave you now. No, I'll explain what. What is hospital efficiency? Well, an efficient hospital is a place where the optimum resource allocation is used at each department. That means Department of Surgery, they treat patients with surgical complaints, those who need to be cut, sutured, whatever, something with a knife. Cardiology handles people who have heart disease. Lung medicine handles people with pulmonary disease. And radiology performs the X-ray, CT, MR, ultrasound, which are necessary, and not the other ones, which are not supposed to be performed anyway. And emergency medicine handles all the acute patients, etc., etc. Anesthesia handles people who need their interventions, and so on. Then, what is emergency medicine? How many of you are emergency medicine specialists, physicists? Quite a few of you. You will come from very different countries, from different departments, and you have very different definitions of what an emergency department is and what an emergency physician is. In 1799, the French Scientific Society decided that 1 meter is 1/10,000,000th the distance from equator to North Pole via Paris. I would say go measure that with a piece of rope and then divide it in 10 millions and you have 1 meter. And then to show that, or to perfuse it into the population, they made this meter that they put up in different places in Paris so people would know this is a meter. They also made a platinum bar, which for some time was placed in Paris, but I couldn't find a picture of it. But this is one of the, I think they have 12 of the meters placed around in Paris. Now, emergency medicine, that is a little different. So I'll say, what is emergency medicine in my department? We have a catchment area of 324,000 people. Last year, we saw almost 60,000 emergency contacts, plus 35,000 minor casualty. That is, I don't have the responsibility for the minor casualty department right now, but that is 162 patients that I handle every day. That's my responsibility when I'm doing my clinical shifts. That makes us the second largest emergency department in Denmark. We have 400 trauma a year, level 2. We have 1.5 trauma medical emergencies a day. That is not ambulance with horns and lights. It's the ones with a systolic pressure below 80 or a respiratory frequency above 30. It's like severe medical emergencies. We have 52 abdominal emergencies once a week, not very much. And we have only 12 ED cardiac arrests. I very rarely get to do anything with those. The great difference between Denmark and Norway, Sweden, and Finland is that all our patients are referred. In principle, we don't have walk-ins. That is, either the family practitioner, the out-of-hours medical service, or the ambulance refers the patients to my care. So I have a filter in front of me. I'm very grateful for that, even though I think the filter is insufficient. And that is one of the major reasons for what I do. My department looks like this. If you look at the red, that is me. That is the emergency department. I have 33 treatment slots. We touch every patient that comes in, and 70% leaves. I can send them either directly into the hospital, I can send them to short stay. Short stay, that is not emergency medicine. If your hospital wants you to run a short stay, run away. Let the other specialties do that. They can go and do rounds if they like to. We cooperate very well with the other specialties, and it's very good for them to have a short stay next to the ED. But the ED, that is here, and that is me, and others. The milestones for us was that in 2007, the medical authorities in Denmark said, acute patients, it doesn't really work. We have 43 hospitals, we do it very poorly. No specialists in the emergency departments. It's junior doctors who stand around there alone and they have no help, no assistance. So there's a policy reform to reduce it to just 21, but with a lot of freedom. So we had 21 different departments with 21 different organizations in a small country with now 6 million people. And emergency medicine was not established as a medical specialty until 2018. So who was going to run these 21 departments? And for me, in 2020, an independent model was presented in my hospital. These concepts are very important in Denmark. An independent model, that is a model where the ED is staffed by emergency physicians. That's the gold standard. A virtual model, that is a model that is staffed by other people. So you have an ED, it's staffed by cardiology and surgery and infectious medicine and what have you. And then you have the hybrid model, which is somewhere in between the independent and virtual. In truth, we are all hybrids to some degree, no matter what we say. But I like to look at myself as an independent model. Life was not always like this. This slide is in Danish, and you can see my hospital, that's the red one, and that is crowding levels, we are around 30. And the average in-hospital crowding levels of the hospital behind the ED was around 15. We were worst in class. Very poor performing. These data are from the Danish national television. Haven't been able to reconstruct them. But what happens is that in 2020 here, my department changes into an independent model. And that means that the role of the emergency physician is not saying, go someplace else. It is figuring out what is the disease, what is the problem for this person. Is it a good thing to be in the hospital? Or should you be someplace else? And if you're going to the hospital, where do you want to go? Until then, we tried to control the capacity in the hospital by bed managers and other creations of the evil one. Because an empty bed cannot be filled with any person. You have to put the right person in the right bed, otherwise things will be very slow. I know orthopedic surgeons, they can treat pneumonia. They're just very slow. So if I fill up the orthopedic department with people with pneumonia, I have a problem next day because then the hip fractures can't be in the orthopedic department. So I need to put the right patient in the right bed. I couldn't reconstruct those data. I had a hard time with my data department on how do you measure crowding. Do you count how many beds are occupied at 16 hours? Do you count how many are occupied at 23 hours? If you want to figure out, is there a rush hour problem around Stockholm? Do you work the average over 24 hours? Or do you look at what is on the freeway at 1600 hours? So I'll introduce the concept of bed days. So one bed day, that is one hospital bed occupied for 24 hours. That means that if two patients each are in a bed for 12 hours, that makes up one bed. And that's an exact measure of what is the strain of my work on the back, on the hospital behind me. So in this paper, we measured the resource drain of hospital beds created from emergency medicine contacts. And what we found was that in period 1, which was taken before the organizational change to an independent model, also free of COVID restrictions and other tedious things, we received 40,000 patients. In period 2, which was put as late as possible so we had time to implement the independent model, we had an increase of 20%. We had 48,000 patients. But in period 1, we drew almost 100,000 bed days from the emergency medicine contacts. And in period 2, we only drew 80,000. So just by implementing an independent emergency department, even though we had more patients, we spent less of the resources at the hospital behind us. You can see it here. This is for the total hospital. Period 1, 100,000. Period 2, about 80,000. Internal medicine, including cardiology, were reduced from 62,000 to 52,000. Surgery was reduced from 22,000 to 16,000. And neurology was reduced from 15,000 to 9,000. That's a good way to make friends. Now, let's play the math. The facts. ED contacts in period 1, 40,000. ED contacts in period 2, 48,000. And I just drew the data for 24, and we had almost 60,000 patients. 60,000 patient contacts in 25. It comes up like this. So in the period 1, we had 109 patient contacts a day. When I started in emergency medicine, I thought more than 100 I would die. In 2019, we had 109. In period 2, that was increased to 132 patients a day, and last year we had 162. This Monday, we broke the record with 212 patient contacts in one day. Morten, who's sitting over here, is still alive. He was on the shift. 212 patient contacts for internal medicine, for surgery, for neurology, for cardiology, and on top of that there was 105 minor casualty. That was also one of the more prosperous days. So this is what it looked like. We came from about 100,000 bed days in period 1 to 80,000 bed days in period 2, and we did increase some. The catchment area has not increased. So we have gone up a little in 25. Now, if we had just worked as usual and not implemented an independent emergency department, I know this is hypothetical, but say that if this many patients generate this many bed days, then 20% more will generate 20% more bed days. And when you have 50% more, you will have 50% more bed days. Imagine what my hospital will look like. From 2019 and to 2025, my hospital has been reduced by 100 beds. From 650 to 550. It would have broken down if we hadn't been there. Now, who sees the patients? These are not quite comparable times. But in 2019, in the virtual ED, the cardiologist saw 19 patients. In 2025, I allocated 17 patients to them. But I had 50% more patients to choose from. Internal medicine, they saw 30 patients a day. In 25, they saw 25, and neurology was decreased from 12 to 8, and surgery was almost halved from 23 to 13. It used to be that the largest single specialty, aside from orthopedic surgery in an emergency department, would be surgery, general surgery. But 80% of the people who go to general surgery in a hospital don't need to be operated. So you can just send them home. You don't need to disturb the surgeons. Let them do what they're best at. Go operate the hernias. Go operate the cancers. Do something else. Don't you waste your time on people who don't need to have a knife. And that was with a 34% increase in patient contacts between 19 and 25. Now, if I hadn't been there, the other wards would have been busy. The gray numbers are what they would have seen hypothetically if they would have had the same share of patients in 19 as in 25. What can we see from this? I would like to introduce the concept of indicator diseases. This is a type of diseases which are always treated in a specific specialty. Appendicitis is not treated by cardiologists. It's treated by surgeons. Stroke is not treated by orthopedic surgeons. It's treated by neurologists. So every person with a stroke goes to neurology sometime. So if I see what is the percentage of patients that I allocate to neurology who have stroke. In 19, it was 13%. In 25, it was 21.5%. The neurologists are happy. The surgeons went from 4.4% appendicitis to 8.5%. Of course, it's not going to be 100% because they also need to see small bowel obstruction and cholecystitis and other things like this. But this is what makes friends. When the chief physician at the neurology department left a few years ago, he said that the three major achievements, the three major points in neurology in his lifetime was 1, thrombolysis for stroke, 2, introduction of MRI for diagnosis of stroke, and introduction of emergency medicine. We didn't ask him to do that. We were at the reception and were very happy to hear it. It came from his heart, and this is how you make friends. So how to do? One of the things is that you need to implement a fast track place where you can help run through patients very fast. I have, in my fast track area, I run 40% of all these 162 patients a day. They go through my fast track area. Most of them go home from there. And then you need to have a competency assessment of your physicians. The great Achilles heel in my emergency department is that in this room you have 33% of the emergency medicine specialist physicians at my hospital. The two of us, Morten and I. So there are too few specialists, and we have to run a lot of this on junior doctors. I'm really looking forward to the time where I have enough. And in my department, I want to have 42. And it's from calculations. It's not from the Hitchhiker's Guide to the Galaxy. This is a lie. Disclaimer. Anyone thinks this is true? I mean, crowding. It's emergency medicine. It's everyday life. In an ED, if you don't like it, you're not tough enough. Go play someplace else. You're soft. You don't like crowding? No. This is a lie. And now back to facts. Input, throughput, and output. This is what comes in. And we have tried to do something so we got fewer patients. As I said, my catchment area is 324,000 patients. 324,000 people lives in my area. That's the people I cater to. And that was about the same in 2019, and now I have 34% more patients. Output, that is the hospital behind me. And throughput, that is me. Which tasks are best solved in the ED? And which tasks are better solved by someone else? The ones that are solved by me, I can solve. I can do something about that. So one of the things we do in the fast track study is that we work on the throughput section. We have tried to reduce input. It is not possible. We have worked with output. That is possible. Because if you deliver the right patients to the right departments, you make friends and they like you. We asked them, what do you want? Infectious medicines, they said, we want meningitis. I said, okay, if you want meningitis and nothing else, can I close your department? So they found something else too. We made this for all the specialties, and that means that if I find a patient with COPD, they go to lung medicine, always. If I find a patient with acute coronary syndrome, they go to cardiology, always. It's not that you can say, well, today, acute coronary syndrome, I don't have a free bed in my cardiology department. Can you call me back later? No. I'm the giver of gifts. And you made a wish list. And if I cave in to the idea that just because you filled your department, this specialty patient is not for you, then you're not going to solve your own problem. I'm Santa Claus. I come with the presents, and I'm very good at giving the right presents. 21% of all the patients I hand over to neurology have stroke. That is very good. 8.5% of the people I hand over to surgery have appendicitis. They like me. Life was not always like this. This is November 2022, before we had the fast track. We had 200% crowding. I was on call that day. It was a nurse who took the picture because I had my head down. I had a very hard time discovering the disaster I was in. I had 17 patients waiting somewhere outside to get into the hospital. I had 21 patients in my waiting room. I had 200% patients in my ward. Short stay was full, and so was the hospital behind me. This is the disaster. I should have called the hospital directors and said that we are in a disaster situation. But I was too busy, so I didn't. Now, background. Crowding is a major patient safety concern. It has negative impact on the healthcare system. It has negative impact on you and me as healthcare providers. And we hypothesized that we could control the crowding if we did a multifaceted approach to fast track of selected patients. That is, we had the input, the GPs, the out-of-hour service, the ambulance service sent patients in. When they arrived, a nurse would look, is this a patient who would be very good to send to fast track or not? And then they'll go to fast track, something would happen. And we made a quite large fast track section. We had 18 beds. And we had 15 beds in the slow track section. I have 33 treatment slots to my 162 patients a day. I have them at a median time of 2.5 hours in the fast track section and 3.5 hours in the slow track section. So slow track is not very slow, and it's not because we push them to someplace else. It's because we figure out what their diseases are and send them to the right place. So an initial nurse has to assess the patient and say, is this a fast track patient? No lists of diagnoses, because when people arrive in the ED, you don't know what their disease is. They don't come with a diagnosis, they come with a problem that you have to solve. So the nurse has to say, this looks to me like a patient who needs to go to fast track. And that also means that if slow track is full, and someone comes who needs to be lifted and can't be ambulatory, don't put them in my fast track, because then you could create a problem for me for the rest of the day, because I can't get them out of there. we had to improve the path of the patient. That is, you go to the front desk and say, hello, I'm ill. The secretary scribble down. Then you go over, have your blood test. Then you go into the waiting room or into the ward. I want blood tests up front on everyone. This is the discussion point. And I think some of you might have another idea about that. But when I have my patients in my fast track for 2.5 hours, the basic runtime for blood test is 1 hour. If I delay my time by an hour, my department will break down. So I need the blood tests up front on everyone. And I'd recommend you do the same. Then you made chairs or gurneys instead of beds. You know, you sit in a chair, you know you're not going to stay there for long. If you dress someone up in hospital clothes, put them in a nice soft bed, give them a duvet, they think, oh, I like to stay here. This is better than a hotel. Room service all the time. And then you need to be treated by a decision-competent physician. And I'll come back to what that is. And of course, there needs to be a slow track area for the other patients because ED patients are not all fast track. It's all kind of patients. And we need to take care of all our patients. So how do we measure crowding? Well, how many patients do you have in your department? How many treatment slots do you have? And then do the math. Again, I had a very hard time with my data department because they didn't want to realize that patients in my waiting room were also mine. So they did, if you look at the official hospital board for crowding in the emergency department, they only look at the beds in the ED, and they are very rarely above 100. But they don't look at the people in the waiting room. You need to include them, because if someone have a cardiac arrest in your waiting room, you can't say, that's not mine. You know, they didn't have a bed. Call an ambulance. Doesn't work. You have to be able to sit in your own closed and dental chair. So you know you're welcome. You always like, well, do you like to go to the dentist? You're happy you're there, but you don't want to stay. And that's the same in fast track. You feel welcome, and you know this is not for long. So we did 121,000 patients. We registered them from fourth quarter of 2021 to first quarter of 2024. That is after COVID, so we're out of that. And then until as long as we could draw it. We drew the numbers automatically from the records to have as exact measurements as possible. It's also difficult to do 121 by hand and then put them into a computer. And then we compared the crowding before and after the ED transformation. And the people we put in the fast track area were those that the nurse said, this is a good idea. Okay? What is a decision-competent physician? Mind you this is a formula. It works. Qualification. The competency of the physician is a function of his knowledge, his skill, multiplied by his velocity in the ED, multiplied by his motivation for being there. With her right tools at hand, right patient selected in front of her, blood test up front, POCUS, what have you. We measure this on all the doctors. Even if you are hired in my department and you're a specialist, we have to figure out, are you right for this job? If you can't have the right speed, you can't run the fast track. I myself am mediocre at fast track. And that's because when the consultant is in the fast track, I get all the questions that I get no matter where I am. Can you supervise this ultrasound? Would you like to see this? I'm disturbed all the time, so I can't concentrate on it. But that's okay. We measure it for all our doctors. You can say velocity, we draw that out of the hospital records. We see how many patients does this doctor start, how many patients do they finish, where do they send them to. We measure the knowledge because every month we have a meeting. Today, more than I weren't there because it was held this morning, where we discuss what is the status of this junior doctor. And we can see the motivation. If your motivation is wrong, you're not going to perform. You want to be something else. Your wife or your children are ill, you perform poorly. And then we can help people with increasing their qualifications. And the result was that we reduced times with crowding more than 130% from 124 hours per quarter, also a quarter that is a 3-month period, before the fast track area, to about 20 hours per quarter after we implemented the fast track. I think that's pretty good. And in this 2.5-year period, we had a stable influx of patients, 135 patients a day. And we didn't increase the readmittance. It wasn't that we said, go out, and then they'll come in through the back door. Go out? No. We didn't increase it. And it's sustainable. You see, we ended the study somewhere around here, but I drew the data just for you until January 1st. It still holds. This is where fast track came. And the funny thing is that you have to watch your numbers all the time because we didn't know what we had done. When we reached the summer in 2023, we thought something must be wrong. Every time you walk into the department in the morning, we have 30 or 40% occupancy rate. What's wrong? We used to have 100. And then we started looking back. So you have to watch your numbers all the time. We may get problems because, as you can see, until here, we have about the same number of patients. That's the yellow line. But it's going up now. And last year, we were at 162 patients a day. And there may be a breaking point. There's always a breaking point. So we'll see what we can do about that. But when you look into a screen like this, compared to the one with 200%, you can see, well, it's pretty cool. It works out. I'm in control. If that was the screen at 8 o'clock in the morning, I would say, we have to do something. I have a problem in 2 hours because for some reason the occupancy rate is 76%. And it's not supposed to be like that in the morning. And that's very difficult to explain to the departments behind you. Why do you have to move this elderly lady at 2 o'clock in the morning? Can't you wait until tomorrow? No, I can't wait. Because this figure has to be 35 or 40. Otherwise, someone's going to die. And I'll show you that in the next paper. Because if I have to start by cleaning up from the day before in my ED, I'm behind schedule. I need to start with a clean slate. This is submitted. The first reviewer has looked at it. We haven't got it back, but we hope to get it soon. And it's about how you can reduce emergency department cardiac arrests by controlling crowding. Methods. We looked at 160,000 patients in the period from October 1st, 2021. That's the start period of the previous paper. That's when we did the fast track. And then we controlled it until December 2034, so we took the time period a little longer. In that time, there was 284 in-hospital cardiac arrests, of which 72 of them occurred in the ED. 12 of those was last year. That's outside of that period. Period 1, before crowding. For ease, I've taken it down to what is the risk of a cardiac arrest per day. And this is the risks, the mean daily cardiac arrests with the crowding period, and this is when crowding stopped. I think there are 550 patients in 550 days in the first period and 650 or something in the second period. And it happens there. The moment we control crowding, we control cardiac arrests. And that's something that occurred to us also because we thought, well, we get these data back. Why don't we have any more cardiac arrests? Oh, it happened on April 1st, 2023. Odd. But you can say the risks of a cardiac arrest on the 200 and something days where we had less than 100, crowding didn't occur, we had less than 100% occupancy rate, is 1 every 2 months. I can live with that. I mean, people come to the ED because they're ill. Of course, some of them is going to have a cardiac arrest once in a while. When we increase it to between 100 and 129%, it's 1 cardiac arrest a month. It's still controllable, but you see the trend. When we round 130%, the risk is 1 cardiac arrest every week. This is very strong when you're going to discuss your budgets with your hospital directors. You want to do a cut, so we go above 130%. Be my guests. I'm not going into the press. You go and explain why we have all these cardiac arrests. We used to have a well-functioning emergency department with a reasonably low number of cardiac arrests, and now you have made this, not me. I can fix it for you. I'd like to fix it for you. So, always be prepared. When the wave hits, you want to be on top of your board, not like the poor soul in here. Surfing is a lot of fun. I'm very bad at it. The wave hits every day. And then the last slides, because there were some questions about who is going to lead, who's going to staff the ED, how many people do you need? Well, the Skåne region did a report in 2014. They have taken it down from the website, but if any of you want it, I have it. They made a measurement and they said that they wanted 170 specialists in emergency medicine in the Skåne region in 2014. And if I count from that, in Denmark, I need 700. I have 193, and I want 42 of those in the clinic, in my department. You can come. One of my other favorite sites is Australian College of Emergency Medicine, where they have done this G23 guideline, and they have done it for almost 30 years. And I have copied it as long as I could because the old copies go out of print. But they have looked at how many emergency physicians do you need to staff an ED department, depending on how many patients, how many emergency department contacts you have. You need one ED emergency medicine physician specialist for every 2,250 contacts. I want 42. And there has to be some for you as well, because you'll need them as well. It's a little less than the one from the Skåne region. And you can say that both in Australia and in Sweden, there are a lot of walk-ins to the EDs. In Denmark, it's a referred system, so our patients have been through a filter before they enter. So maybe I need a little more than you do. But a minimum of 42 in my department, as opposed to the 6 that I have. So that was what I had for you. And now I would like to have some questions.
Thank you so very much, Halfdan. That was fantastic. This is how you make friends. And I'm the giver of gifts. So I'm the giver of the box and those two phrases. Samar, all the way at the back.
Hello. The fast track staffing, is it the whole day or in a specific part of the day? Can you mention something about that?
In principle, the fast track is staffed from 8 o'clock in the morning until 23 in the evening. The medical staff in the fast track area is either a very early, in Swedish, ST-läkare, or hopefully someone in the later part of their ST-läkare time. But the thing is that the concept of the fast track continues 24/7. So it's always there, but it's not manned specifically until in the prime time.
Thank you.
Just a question about the labs. You say you want ready test results for them to be in the fast track. But where do you keep them before? They stay in triage until you have the labs and then take them to fast track? Or how does it work?
The labs of the patients?
No, the patients. Where do you, like the flow of them? Because you said you want already labs. You don't want to wait for them for 1 hour there. Or maybe I misunderstood.
You register at the desk. Then you walk over here, just by the lab. You have a needle in your arm, and then either you go in the waiting room or you go into one of the dental chairs. Was that the answer? Was that your question? Yeah. No.
If we just wait so that everyone can hear. If we chuck the red box over to the other side.
I love the idea of a fast track. Young people, 20, 30, chest pain. We need an ECG. Please don't take off your warm coat. It's cold outside. How does it work? And also, how many nurses and orderlies do you have working with taking the blood tests?
The blood tests are taken by the lab technicians, so that's not our nurses.
So how many do you have there?
I don't know. It's a different department.
We do have a problem here at Södersjukhuset that we're overcrowded in the waiting room, just send everything down with nothing being done.
Yeah.
With inexperienced nurses, because we have a loss of nurses every year. They don't want to stay working in the emergency department. And my last question, which is actually a question, it's how many ER docs do you have in the emergency working?
How many what?
ER docs, like emergency docs,
Yeah.
working in the emergency department? 6. And so,
the rest of them will be ST-lægere or RT-lægere.
well, so you don't have any organ specialists, so to say, surgeons, internal medicine, or
they'll be in the short
cardiologists?
stay area.
Excuse me?
They'll be in my short stay, in the hospital's short stay. It's not mine. So I have the other specialties in the short stay, besides the ED.
But the slow track, who's
The slow
working in
track,
the slow
that is
track?
me.
With 6 ED physicians 24/7.
Yeah. So
Okay.
either that, or we'll run it with ST-lægere in the later part of their training.
Okay.
Thank you, Halfdan. You touched on some of the differences between Denmark and Sweden, with Denmark being what do you call
Referred?
Referred, exactly. Referred, and here it's lots of walk-ins. Another difference is how easy it is to get follow-up quickly, and I wondered how much of the fast track hinges on being able to have follow-up within a couple of days.
You saw that the surgeons went from 23 patient contacts a day to, what was it, 13? That meant that they took out a specialist doctor from the short stay and a junior doctor from the short stay and did something else with them. So they could upgrade their outpatient clinic, they could upgrade their daytime surgery, and I have very few problems. Sometimes we talk about how do you make a very fast follow-up in some place. I nearly always get it. So by making sure that the right patient gets to the right department and that only people who needs to be in the hospital enters the hospital, I have free resources which they can also use in the outpatient clinic. So it's very rarely a problem.
Brandon. Sorry, Philip.
Ready, Brandon?
Hi. Can you run through a referred patient coming to the ED? How is triage working? Just like break it down, because I'm having a hard time understanding. They're meeting someone in the at the desk first. They're getting written into the ED. Then, I mean, are you taking parameters? Is this nurse is just doing it by feel? Oh, you look sick. Can you describe it a little bit better?
If you arrive by ambulance and the ambulance are worried, they call us up, and then we meet at the resource. If you arrive by ambulance and they're not worried, they call us up and they'll be allocated a bed. As for triage, I'm looking forward to the day when we finish with that waste of time. Aside from the nurse saying this is a patient which is suitable for fast track, or the nurse saying this is a patient who is in imminent danger of dying, I don't need triage. As examples, if you look at people with intestinal perforation or small bowel obstruction, that is time-critical surgical diseases, in the triage system we use, only 30% of those are triaged orange or red. 60% are triaged yellow or green, which means I don't care. Well, I do care. These people are going to die if I don't see them. And it's time critical that I see them fast. So I'm looking forward to we are done with triage. When the patient is in the waiting room, we have a nurse monitoring the waiting room and taking the patients in and doing the vital signs, so I have them when I see them in the fast track. If the patient is admitted at a hospital bed or right to a chair, the nurse responsible for that chair will do the vital signs there. Technically, that will amount to a triage according to the eye-depth triage system, and I don't care. I just need the vital signs, and then I'll do the rest.
That was an acronym, the IDEC trio system, yeah? I don't care, or was it another?
No, depth Danish emergency project triage with, I think, 62 different cards, depending on symptoms, and very, very difficult and very, very time-consuming, and not validated in any way. IDEPT a little easier, but still not very much use.
Thank you for a very nice presentation, Halfdan. Can you explain the increasing number of contacts to your ED in the recent years in the same population?
No, I can't. But I can say that it's not only my hospital who receives more patients. It's all the hospitals in capital region. I'm not quite sure what it is in your part of Denmark. I'm not quite sure if you have the same in Sweden, Norway or Finland. But it is a hassle because most of these patients don't need to be at the hospital. And that's also one of the reasons that I can send them home so fast.
About sending home so fast, which you must be doing, none of the data there that I saw was about patients that went home. Have you got any data to say that they're not dying more at home with cardiac arrest out of hospital, or since this, or is there any signal for you of increased reporting of inappropriate discharge?
I don't have data for out of hospital cardiac arrests, but you can say that if you look at the readmission rates, if you take the data from the Danish emergency contacts database, we have 6.2% readmission within 72 hours in 2025, and that is the lowest rate in the capital region of all the 5 emergency hospitals in that region. So our fast track does not mean that patients are returned like boomerangs. We do the right thing for them. They're happy, they don't come back. And also when you control crowding, before this, if I hired 10 nurses on January 1st, 9 would have left before Christmas. Now, if I hire 10 nurses, they're all there. So our turnover is very low, which also means that I don't need to spend resources training new people that much. So they like being in the department because controlling crowding is a way of improving satisfaction for the medical staff.
I also have a question. One big issue in Sweden is that we don't have enough beds in the hospital where to admit our patients from the emergency department. You said you always admit orthopedic patients to orthopedics. How do you manage to convince the cardiovascular surgeons and so forth to actually take on their own patients when it's full in the department, I mean?
Well, for one thing, if there's a lack of orthopedic beds, I can't solve that. But I can help them by not putting gynecology patients in orthopedic beds or cardiology patients in the surgical beds. So by placing the right patient in the right ward, I reduce the strain of resources in the wards. So partly by doing the specialty profile, saying, which gift do you want? I'm going to give it to you. And I'll do whatever I can not to give you patients that's not within your specialty profile.
So what happens with the patients that needs to be admitted?
They are admitted.
But if there is no bed,
a bed will appear.
Wait.
We have about 550 beds in the hospital.
if we can just, we haven't got much time, okay? You want to talk beds and actual practicalities, we can go. We're almost done. Jonas.
Yeah, I was wondering about the blood tests. Who decides what blood tests are done?
It's a standard package. And that also means that we take a lot of blood tests which are not necessary.
But you get the money back because it's a faster turnover.
I want the blood test because I don't know which ones are relevant when the patient arrives. I can qualify it, of course, if I wait until I've seen the patient and decided, in this case, I don't need liver enzymes, whatever. But I'm faster because I have the jigsaw puzzle pieces when I see the patient.
So ladies and gents, that's time. Doesn't mean the conversation stops here, but I think I'll welcome you all to be able to stand up and go outside because it's been a full hour and it's been a long morning. But I imagine that people want to continue this very provoking systems discussion now and this evening and beyond. Okay, so enjoy lunch.